Ciao mondo, hello world, hola mundo, hello mon, konnichiwa, ni hao, namaste. We're here once more at the Vicenza International Course on Critical Care Nephrology, AKI, CRRT, extracorporeal blood purification, and I have the pleasure today to share some considerations about biomarkers with Stuart Goldstein, of course, no need for introduction, and Giovanni Ceschia from the University of Padua, who spent some sabbatical time in Cincinnati. And I want to go straight to the point and ask Stu, how do you see NGAL affecting your practice in terms of unveiling AKI and triggering application of CRRT and starting different interventions?
Thank you, Claudio, and thank you again for hosting this wonderful meeting. Yes, so we've pretty much automated the use of NGAL in our ICU population through the Taking Focus 2 protocol. We have automatically programmed the renal angina index into the electronic health record, which results at 12 hours. About 10% of patients will trigger being renal angina positive, and then an NGAL is automatically ordered from our clinical lab, so there are no humans who are involved. If the NGAL level is below detection limits, then patients get the usual standard of care. But if the NGAL level is elevated, then there is a clinical decision support pathway for fluid administration, use of diuretics, and if patients get to a certain fluid accumulation, the consideration of CRRT. So it takes a lot of the guesswork out of caring for these patients. And what we showed in a publication last year after we implemented this, we could decrease the time to CRRT initiation, we decreased the duration of CRRT initiation or provision, and for patients who survived, we decreased ICU length of stay and time on the ventilator, ultimately decreasing cost. So it's been a very effective tool for us to standardize medicine and also personalize it for patients. And we're now starting to work with other institutions to implement the same type of clinical decision support at their children's hospitals.
So we had a similar observation in Vicenza when we implemented our study on biomarkers, and NGAL was very useful in making decisions. It's a little bit like asking for troponin when you have a non-STEMI situation in a patient, right? So this brings to the concept that you should not order biomarkers for everyone, but you should just order biomarker in the moment of uncertainty when you have some suspicious situation, and at the same time the uncertainty does not provide you the ability to make a decision. So this is more than a simple prediction. It's a little support in something that you have already suspected, correct?
I agree with you 100%. And what our intensivist told us is we don't think we're doing more CRT for patients. In fact, we saw no increase in the number of patients treated with CRT. What they said is, we think we're starting sooner in the patients who would have gotten it, and therefore we had improved outcomes. We in fact started 2 days earlier, and we decreased their time on CRT by 6 days.
In our experience, we even reduced the number of patients who required the CRRT, because we were able to implement the protective and protection measure much earlier, and therefore this was a significant improvement in the overall approach.
Fantastic.
So, Giovanni Ceschia from University of Padua spent some time in Cincinnati. Hopefully was a fruitful stay, I guess so. But it seems that you are studying the possibility of using this NGAL biomarker to understand the moment of potential liberation from CRRT, right?
Exactly.
Is that correct?
Exactly. Thank you, Professor Ronco, for your question. In my time in Cincinnati, we looked at the urinary NGAL levels measured during CRT in PQ patients. And what we understood and what we learned was very interesting, because the median NGAL levels during unsuccessful liberation attempts was more than 10 times higher than the median during successful liberation attempts. And we discovered that the cutoff of 900 nanograms per milliliter was very good in predicting successful liberation, and with an area under the curve of 0.95, so very high. The second thing we've learned was that this biomarker was also useful for predicting the duration of CRRT. So we measured it in the first days of CRRT, and it was very useful to predict the duration more than 1 week, with the cutoff that was higher, to 2,600 nanograms per milliliter, with again a very good area under the curve of 0.85. So, and we defined a prolonged duration of CRRT as more than 1 week.
So this morning at the Vicenza course, we had the chance to attend the debate between Professor Kellum and Professor Kasciani on the use of biomarkers in one side and the use of standard urine output and creatinine as a main tool to diagnose, predict, and work with intervention on AKI. And the conclusion at the end was that these two aspects are complementary. They are not mutually exclusive. They are really something that allow you to refine your clinical understanding of the syndrome. And I made myself a personal observation that creatinine, unfortunately, is not telling us the whole story of AKI and of a potential injury to our kidney. Remember, one patient with one kidney may have a normal serum creatinine. So creatinine tells you very well what happened once you reduce kidney function significantly, but doesn't tell you anything on what is going on before that. And this, unfortunately, is exactly the time window where we would like to implement our protective and protection strategies. John Kellum wrote several years ago, now that we know, we cannot just neglect this thing. We are somehow obliged to take a position and make intervention to protect and protect the kidney and prevent it from AKI. So thank you very much for joining today, Cappuccino, and hopefully this will lead to what we call a routine use of NGAL, which is not necessarily meaning NGAL in everyone. Means routine use when you have a suspicion of a risk condition or a potential condition of AKI, and allows you to refine your understanding of the situation of that patient. The more you use it, the more you learn how to use it. This is my impression. Do you agree with that?
Absolutely, yeah.
And also having this new information about urine NGAL in patients undergoing CRRT, etc., may provide information on how really to decide when to stop and also have an effective stop. So thank you very much for joining Cappuccino today from Vicenza, Italy, with Stuart Goldstein and Giovanni Ceschia, and have a wonderful day. Excellent.
Excellent.